them seriously. Say thank you, because it's a lot of hard work. Even the communication that goes out, our communication committee. Dennis Conway, where's Dennis Conway?
Downstairs.
Oh, downstairs, stand up, Dennis. All right, Dennis from ATC. He's the only guy that can out-talk me. There we go, I like that idea, there we go, all right. Do I dare, do I dare? See, what did I tell you? All right, before we begin, I'd like to give a minute to the folks at Microsoft. They gave us the space, but they're also going to live stream this. So anybody that gets up and tries to do a photo bomb against me, it's going to show up on the live feed. I just want to let you know that. So just get ready for that. All right. So Jamie, are you going to do it? Samantha, there we go. That's it.
I'm Sam Brown. I'm a Teams technical specialist at Microsoft, and my customers are all in healthcare, so really glad to be here today. Just wanted to give you some context on how we set up this event, and hopefully a little bit of context on what a lot of our customers are using Teams for, and then we'll toss it over to the panel. So.
Oh, here comes the technical guy. Hold on. Samantha can't talk as loud as I am. You got that right.
Yeah. Thanks, Alfred. Okay, so in terms of the healthcare communication architecture, we're all very aware that it is a complex beast, from medical records to communication, whether that be a direct message or a text, physical phones, operators, the meetings that we have in terms of rounding and training, collaboration when it comes to documents or dashboards, alerting, maybe a lab update, processes and portals, paging. I mean, when you think about it, it is very complex, right? So what we're doing with Teams, and the reason and the story behind it, is that we're trying to make it simplified in an all-in-one solution. And so it really goes beyond just the communication when it comes to Teams. So yes, you can go in the morning and you're able to see, okay, here's my meetings for the day, here's who I'm talking to, here's the context, here's the files that I need to prep, all in one place through like chat and meetings and calls. But then also you can collaborate with the actual content from the Teams with the context that you need within the tool. So the good news is that you can customize it and extend it, so it's not just Microsoft services. Anything that you're using during the day-to-day, we have a lot of third-party apps that you can just integrate really easily, so it's a one-stop shop for you. And obviously in healthcare, we're dealing with a lot of really sensitive data. And so we need to make sure that this is enterprise level security compliant, and it's all manageable in this business admin center. So that's all we wanted to say on Teams. We can definitely answer your questions. We're going to be outside today. But this in particular, this meeting that we're having right now, is a live event within Teams. So that's different than the most of the meetings that you'll just dial into with a smaller group. It's meant for like one-to-many. So that's what we set up today. And I just took a screenshot of this because I know for me, before coming here, I had so many meetings where I would wait for 10 minutes because we had to add the right room and we had to add the right people, and you're just like constantly frustrated on why this can't get started on time. So the cool thing here that I wanted to highlight is this proximity join. So we actually have, So we actually have at the bottom of this screen, you can join and add the room. So when I dialed in, it automatically came up with this room and I just didn't have to worry about it. So you can use this live events for 10,000 attendees, and you can use it for webcasts if you want to save it later, or for example, for like an all hands meeting that you might have for everyone in the company. So with that, we again have a lot of toys for you to play with, devices. We'll be outside if you have any questions, but just wanted to give you some context there. So we will turn it over now to Tony.
How come? I don't know. I don't understand that. So what I want to do now is, this will be a live feed that'll come out. It will be recorded, and then we'll share it with our friends at HFMA and HEC, so they can then share it with the rest of their organizations as well. I'd like to do is, Nick Christiano is the president of the New York State chapter of HIMSS. I'd like to introduce him. He's going to introduce the panel. And watch the boxing gloves come on. Thank you.
Good evening, everyone. Can you hear me okay?
Yeah.
Great. So this is going to be an incredibly interactive discussion tonight, which means that while the panelists are going to be debating, and this is going to be a debate, I'm going to roam around the room. And if I find out that you're not paying attention or you're texting or you're looking at emails, I'm going to come over to you like this and ask you a question. All right? So this is like your worst nightmare when you went to school. You got a professor who's going to run around and ask you questions, because then I don't have to ask any questions. So I'm Nick Christiano. I'm the president of the chapter. I'm also the CEO of Aris Radiology, which is the third largest teleradiology firm in the country today. We service about 220 hospitals. We have about 250 physicians, and we're probably one of the only cloud-based teleradiology solutions in the market today. So I'm going to start with our panelists. On my left, their right, I want you to do a quick introduction of who you are, where you come from, so I'll give you a point of reference, and then we're going to go right into our questions and debate.
Yep, my name is Dr. Raul Vazquez. I'm from Buffalo, New York, so took an early flight. I'm actually an ACO in Buffalo, so I'm Greater Buffalo United Accountable Healthcare Network. We have about 250 primary care doctors. We're involved in 2 value-based agreements, but we're trying to get everyone to understand it a little bit more.
Thank you. This is home for me. I used to be a part of HEC and did some work with them on golf outings and stuff. So I have a lot of HEC friends in here and a lot of work on him. So I'm really humbled and honored to be here. I'm Alan Gilbert, the CEO of BeCareLink. We're an early stage company that has an artificial intelligence digital therapeutic working on 2 major conditions right now. One is falls risk and one is multiple sclerosis. So I really look forward to the panel. And as a honorary millennial, I'd like to call myself that just to make myself feel good. But if people are out there texting, they might actually be talking about this out in the interwebs and in social media. So it's actually a good thing. So I just want to be able to share that.
I'll check
with you.
Good evening. Good evening, everyone. I'm Molly McCarthy, and I work here at Microsoft. I'm actually from the Washington, D.C. area. Took the train up very early this morning after a long night of, unfortunately, watching the Nationals lose to the Astros. So I'm recovering from a long weekend. Anyway, so it's great to be here. I sit on the U.S. Health and Life Sciences industry team. My background is I actually started my career 25 years ago in healthcare as a NICU and pediatric nurse in the Washington, D.C. area. Woohoo, yeah. And actually transitioned over to the tech world about 20 years ago out in Northern California, and have really been in technology for the majority of my career, medical device, been at Microsoft 6.5 years. I sit on the industry team, as I mentioned. We are a team of clinicians, former CIOs, and we help our sellers and our technical folks really speak the language of healthcare. So really getting them out of the IT discussion and more into lines of business. So thank you all for being here tonight, and I'm going to transition over to Paul.
Thank you. My name's Paul Contino. I'm the Vice President of IT for the Guthrie Clinic. It's a 5-hospital system in, can you hear me? It's a 5-hospital system in North Central PA. I'm actually a native New Yorker, but I'm spending my time in Sayre, Pennsylvania. It's a rural area. We service about 1 million patient visits a year. We're a level 2 trauma center, and I'm in charge of the transformation efforts at the institution. So happy to be here and look forward to talking to you.
Saurab Chandra. I'm a critical care physician. I began as a Tele-ICU physician 6 years ago in Cincinnati, and it was a very different experience than what I was used to, seeing patients face to face. And I was just used to think like, how can I do it differently? How can I make it work? And was very fortunate 5 years ago to be hired as the medical director of Tele-ICU at Northwell Health. Northwell Health, as you may know, is the largest health system in New York State with 23 hospitals under the belt. And for the last 5 years, we have been implementing different programs, not just in Tele-ICU, but in acute care, tele-stroke, tele-hospitalists, and then post-acute care in this nursing homes, in rehabs, and now we have a good footprint in direct-to-consumer space as well. And it's been a really rewarding and a journey so far, and a pleasure to be here today.
All right, thank you very much. We're going to get right into our questions. So, digital disruption in healthcare. Now, you can go back to the first slide first. Not really sure what that means. And one of the things we did, and the group got together, we put together a group of questions. So we're going to start off with the first one. Maybe digital disruption in healthcare, we're looking at it all wrong. Maybe the disruption in healthcare will come from other venues like retail health market or the insurance companies or organizations that have deep pockets for developing innovative solutions with a customer-centric attitude and a distribution chain that manages patient engagement at the local level, yet can aggregate at the national level. Is that where disruption will come from? Who would like to be the first panelist to tackle that question? Or do I get to pick? Oh.
I think you're gonna require the same people that create the problem can't be the same people that solve it. So hospital systems are not gonna be the way to happen. I mean, it has to be doctors. I think I've been practicing for 30 years and I've been frustrated by the fact that everyone else has been kind of telling me what to do. And I think it's time for physicians to really take that, so we created an ACO from the ground up, looking at the IT informatics. So, like the movie Tron, we're not programs, we're users. And it's easier for physicians to learn and model this than having a programmer tell you, unfortunately, because we're the ones that are dealing with the patient encounter. And it's real important for us to know the data. We've never known cost data, and the only ones that are going to solve that is right here. The doctors are the ones that create the cost in the system. We're the ones that can control it. Insurance companies, I'm not friends of, but we have to become them, because in order to really do what we have to do, that's important. Teletriage is really crucial. How we treat patients, otherwise we won't exist. Amazon did a really good job, right, with retail, and they're going to do a really good job in healthcare if we don't do something different.
Oh, sure.
So with due respect, and I am a physician here myself, and I'll say one thing, I can't do it on my own. This is a multidisciplinary approach. I'm going to give a shout out to my team here who's sitting and supporting me from finance, business, and operations. You need support from multidisciplinary teams to come and work together to make it a success.
Yeah, and I actually would highly 100%, 110% agree with you on that. I don't think doctors are going to solve it. I don't think nurses are going to solve it. I don't think healthcare alone is going to solve it. And one of the things that I've actually seen in the past few years within healthcare and working with providers really across the country is the willingness for them to come to the table, for technology companies to come to the table and really discuss partnerships. And you'll see it in the news over the past month with many different vendors out there. But really it's going to take the expertise of both the clinicians at the table who are working side by side with one another, as well as the patients. It's going to take the technology experts. It's going to take folks who really understand the customer experience. So I don't believe it's going to be one specific entity.
I think you have to come to Buffalo. We may show you.
I would add that you have a partnership that needs to be there on the business and the clinical side. I've worked with clinicians my entire career, and I got to say that the business side of healthcare is often not the strong suit of the clinicians. And so, without that partnership, you wind up having a broken model that just doesn't scale. ACOs, very different animal. So your success in the ACO is not indicative of what a health system's financial model looks like. So I think obviously there's things that we can draw from the experience you've had as an ACO, but I don't think it scales at the same level that would be needed for a health system. So my view is it's a partnership between the business and the clinical and of course the technology side, which means vendor partners make it successful.
But I would also say that technology, the big companies out there are impacting positively, I think, the way care is delivered. Again, we used to go to the pediatrician for the flu shot. You can now go many places for that. So lots of different companies are looking to disrupt that. we're currently working with our friends here at Microsoft on things we're doing around falls risk. So we're actually using an Xbox camera that our kids use, actually with the camera pointing at you for patients with falls risk. So we're taking a test that was a test you did in the office, and we're replacing that with a test that you do at home. So we're trying to disrupt, and as the little things that we do in our company do that, but we're using tools from the biggest companies out there. So you have to really leverage the things and look at the experiences. And again, going back to me being honorary millennial, millennials don't accept long lines to wait for doctors. They want their information immediately. So there's a whole different paradigm happening, and I think healthcare in general has to be able to react to that.
Yeah, and I think that along those lines, with all of the data and information and accessibility that's out there, comes the new demand for knowledge and transparency of the health system, which I don't think historically has been there. I don't know about you guys, but recently I took my son to an ER down in Florida, and a couple weeks later I received multiple different bills from different segments within the hospital. I didn't see that, 5-10 years ago. But just even knowing, what does this mean? I'm taking my son to the hospital versus an urgent care. What's that going to mean in terms of what I pay as a consumer? Do I want to go, 3 miles further down the road on a Saturday night, or do I want the convenience of coming right here? So I think not only the partnerships within the health systems and businesses, but also the consumers and what they demand, especially millennials like you, Alan, I think will really push the limits.
All right.
We're also dealing with information. So on this watch that I have on my arm, and it can be a multitude of companies' watch, it is now passively looking at heart data. It's now passively looking at falls risk data. It's now passively looking at if you have an AFib in your heart. So even if you're not, it is doing so many things that we're not even all aware of, but collecting so many interesting data points, and all of that is, well, how do you get that back to the doctor in a timely fashion that a doctor can absorb its information? So we have.
Do they want that?
And do they want that, right? Because they just want this tiny little piece of information to be able to treat us. But just know that is there, and it's coming, and it continues to more and more data.
So some of the doctors learn business, by the way. And the important thing here is there's ways to really gather the information. There's so much information in claims data that we don't get access to. In an ACO, we've been able to see, the eyes can only see what the mind knows. And you saw so much data that we can stream it down in a ribbon format, no matter what EMR, if it's a community-based organization, get them the information to really make it actionable. And that's possible now. So I know, big is not always better. And some of the community smaller actually does better. So that's where these big systems may come around, but if you do your homework, you do a better job. But it's really getting the physician the information and letting him develop a team. But the doctor has to drive the process. And some doctors, we're weeds, we don't die. So we are very positive in terms of what we can do. So you've seen other doctors, the new ones, and I'm not a millennium, but I learned from the millenniums a lot. And I think I've got 2 daughters and they taught me a lot.
All right, good. You see, they're getting riled up. That's good. I like that. But I think they missed a big point because they didn't talk about retail health. And so when I was the CEO of a health system, I partnered with Walmart. All right, well, a little bit.
We're not done.
A little bit. And I was one of the first minute clinics with Walmart. And I went down to Bentonville and I saw their operation. And what they did is when they opened up their minute clinics is they basically reduced the cost of care, their component, because they basically said to their employees, here's $6,000, which is part of what we pay. You can do whatever you want with it. You can go buy a TV, or you can use it for your minute clinic, or you can go put it in the bank. But they watched the cost of care plummet for their employees, and especially with mothers, and I'm not trying to be in any way, isolating one group, but they are the major decision maker. Being a retail facility, and their child had the sniffles, and instead of going to the pediatrician and paying a $35 copay and a $150 bill, they would go to the minute clinic, pay $39.95, and get taken care of. So consumerism is going to play a major role in disrupting healthcare. And retail pharmacies and other organizations have far deeper pockets and better interoperability channels than any healthcare system in the country today. What do you guys think about that?
We know interoperability, and we've been in that business a long time, and people on the panel, that's where this all breaks down, right? There's no ATM network for healthcare. So when Molly's child has to go to the hospital, they don't know anything about her. Any of us go into any hospital here, they don't know anything about us. So that's the problem, that yes, the retail, but they're still their own silo. CVS is their own silo, and all these different ones are their own silo. They're all wonderful, but we still have to figure out a way that banking solved 45 to 50 years ago, getting all the banks in the room together and say, you're going to share this information. It's not going to steal customers at the end. Customer service is going to win out. So we have to get to a point in healthcare where hospital A, again, doesn't have to worry about the hospital B down the door is going to steal its patients. If they're better at what they do in their lines of business, their patients will stay there.
Yeah, and one thing is, I mean, a lot of technology is taking place and we're not looking at it. So care quality and fire is real. So I'm in Buffalo. I can ping people that have been seen down here, get access to their whole records without having to call the office. So the connectivity is there now. And the fire can really cross-schedule, integrate the whole system. It doesn't matter what platform you're on. So you're on Cerner, you're on MedDen, you're on Epic. All those things talk to each other now.
Raul, tell them what FAIR is. Some people here may not know what that
fast
is.
healthcare interoperable resource. We're mapping resources with a lot without requiring all the consents. Right now, if you try to get some information from a behavioral to a primary care, you got to give your right kidney and your left eye. And FAIR with these care quality allows you to just stream that data. We actually develop a mammogram unit that's on a mammal unit. We can actually, no matter which of our practices, can schedule in there and we get access to those mammograms without having to call anybody. And we run, so care coordination is the key. IT and care coordinations are key in order to develop anything. And even in every community, social determinants of health we talked about, we've integrated them in terms of how do we do things. So I think if you, like I said, you don't have to be big. So you can bring whatever retail system into the model, but listen, if patients are comfortable and they're comfortable with their patient, with their doctors, these retails aren't going to do the same thing. And if you can show a better product, which is care quality, and it's going across. So if you're in Texas, California, Florida, you get access to that data in your office, and we can actually push it out to the patients.
So I would just add that the interoperability is a key to this whole thing, but I think there is going to be a place for alternate business models, and retail clinics and others are going to play a role. We're also going to have the Amazon effect that's coming with other big platforms that are going to actually push into healthcare. The challenge that was brought up about interoperability is a key one, and I think that the biggest challenge we have is that although there are things like that the eConnect and all these networks that actually are linking records, we don't have a national identifier. So when the retail health organizations get involved, they're not going to. Care quality on the back end is doing a lot of matching of records. There's no direct link between those records. So if we have a CVS Minute Clinic that has your record, it's going to be very difficult for you as a consumer to get all your information linked together. And so that's a challenge right now.
You can actually pull the data because so as an insurer, well, I'm a hybrid insurer. I have all the claims data coming in. So I can tell everything that they're doing within their system, actually a little bit better than even hospitals that don't even know their cost data. Most hospitals don't know anything about their systems. I talked to some of the CEOs about their mortality and their costs, and they look at me like, how did you get that data? It's all claims, and the insurance companies are very powerful and have a lot of the information you're trying to get from SureScript. It's a lot easier to just get it from the source than from a second pair.
Yeah, but we use all that data as well. So you have claims data, you have EMR data, you have external data, you have social data that's coming in. None of them share a unique identifier. None of them have the same identifier. So there's a huge amount of administrative waste that's been created in this country. I think the latest figures on administrative waste in healthcare is something like $800 billion that are being spent. A portion of that is due to identifier issues. Everybody is trying to link everyone else's records together. And that's a challenge. And we still have a congressional mandate against any research into a national identifier, which to me is absurd because we spent 20 years building out EMRs, and now we have an interoperability issue. Why wasn't that dealt with as part of the EMR ARA funding? It could have been. It could have actually been a mandate that everyone has to have some sort of identifier, but we have a congressional mandate against it. So we're struggling with that right now. And it's been years and years where every institution has had an issue with medical records and linkages of medical information. And so as a consumer, when I think about it, I want to have the convenience of going to a Minute Clinic. But then again, my child's record is fragmented in more places now than it ever was. Because unless I'm going to the same pediatrician and getting all the data in one place, I'm going to have 6, 7, 8, 9 different records all over the place. And there's no easy way to get that data together.
But there's solutions. virtualizing this type of model. So we're doing virtual vetting. We have.
Can't hear you.
I'm sorry. A lot of us are doing tele-triage and we're virtualizing it. So we have navigators that go out in the field, and what they do is they have a tidal care unit that can actually listen to the lungs, heart sounds, look at the throat, look at the ear, and you can do a pediatric measure and send the medicines right over to them. So you don't need the minute clinics. I mean, and the cost long-term for those minute clinics, they make their back end on the pharmacy side, but when you control the pharmacy as an ACO and you control the cost, you can limit the minute clinics. You can say it's going to be cheaper or you pay nothing if you go here. If you go there, it's more.
Chomping, it's a bit over here. We got to give him a chance here.
So yeah, so I just wanted to add one thing. The question was, where is the disruption coming from? And in all this discussion, we forget one of the most important stakeholders in this is the patient, who is the consumer. The disruption will come from many sources who are going to be able to satisfy the needs of the consumer, that is your patient. If the retail healthcare is able to provide better service, short wait times, better care, then it will be successful. We in telehealth, if we are able to provide better care while the patient doesn't even have to leave the home, in their homes, then the disruption will come from there as well. So it will come from many sources, and the more the merrier.
And then we can drop tele because it's actually just health, right?
Right. So a couple things.
Digital too.
Regarding interoperability, I'm just going to make one plug for Microsoft, and we announced Azure API for general availability for FHIR last week. But I think too, with regards to the retail clinics, it's a different model. I think in general, many of the retail clinics aren't staffed by doctors. They're staffed by nurse practitioners, which have time and time again through research shown just as effective quality care for less money, fewer dollars. So that's one thing. The other thing I think in general, when we think about healthcare, think about prescriptions that maybe 10 years ago that you would have had to actually have a prescription to go to the pharmacy to fill. And now we don't, they're not required. And I think just in general, as we look at healthcare and we look at the training of healthcare professionals and working to the top of their license, and we think about acute care facilities really treating those chronic, very acutely ill conditions, whereas maybe, in the community, we're treating more not acute episodic care. So I think there's, above and beyond the retail clinics and that model that they're using, I think disruption will come from, is coming from, a multitude of areas, not just retail by any means. And I think at the end of the day, I would love to see, as a patient, as a mom, as, family, I think having that unique identifier, is something that I think ultimately, I want control of my records. I don't know about you guys, and I don't want to have to log into 10 different portals. So I think, to your point, consumers will continue to push until they get what they want.
All right, so let's take a sidestep. What happened to Jamie? That one slide. So digital disruption. We're going to put up a chart. And I got this chart from Alan, and because he's a millennial and he looks at stuff, and I'm a baby boomer, so I still look at paper. And Alan sent me this chart, and I forgot what journal it came from, but it basically identified the biggest areas that would have the biggest impact on healthcare. And I looked at this chart and I said, this chart's backwards. It's upside down. It's wrong. Because quite frankly, I don't care if you have interoperability, if you have AI, if you have really poor security, you're not going to share anything. So if healthcare is investing in those percentages and proportions, we're in trouble because we're investing in the wrong areas. If we went to a bank and basically you put in a card in the ATM and it said, maybe only 70% of the population can look at this transaction, you wouldn't use that ATM. So guys, what do you think about this chart? Is it backwards, or do you agree that this is the right order, especially when it comes to investment and attention in the healthcare arena?
As a telehealth medical director, I think I'm good with how the chart is written.
I don't see telemedicine. I mean, we looked at this chart the other day, and when I looked at it, this is just me working at a technology company. Telemedicine to me isn't a technology; it's a solution. You know, some of these other areas are, you know, interop and cloud and blockchain, artificial intelligence. That's technology. Telemedicine to me is a solution built on some of that or one of those or many of those technologies. So that I saw that and that was my initial reaction.
I fully agree with you. Telehealth is actually a modality of healthcare delivery. It's not technology. And if you look at telehealth, everything underneath actually contributes to the experience of telehealth. Telehealth is AI. Telehealth is interoperability. Telehealth is mobile health. So all of those together come together to help telehealth deliver care.
And I agree with that, but the problem that I have is I go to presentations where I hear that I can see a neurologist who will come with a little robotic device with a little face on it, and it's beamed as, and it's presented as telehealth, when in fact it is not. And what also concerns me is what happens in home health care, where they talk about monitoring chronic conditions and they put it as telehealth, but it's all those other solutions underneath that are being packaged. So from a budgeting standpoint, if I'm a CIO or I'm a CEO running a major health plan and someone says, I want to take 29% of my budget and put it into telehealth, do they really understand that of that 29%, there's all these components, or are they just buying that fancy robot with a nice screen and the talking head?
And I'm just going to comment here because I've seen so many different point solutions, and I think within, you know, if you go in and talk, I went in a few years ago to pediatric interventional radiology room, and they just told me about all the different equipment and point solutions that they had to provide care. And I think that's, you know, if you talk with any IT person within a hospital, and I'm sure there are a ton of them here, the amount of point solutions, like teleradiology might use one particular solution. You might find over in dermatology another solution. I think taking a step back and understanding, of course, your platform and, you know, the overall infrastructure behind that rather than 20 different point solutions is important, and that's money.
I think what we do is the tele-triage is you have synchronous and asynchronous. So if you've got people that want to go into an email, you give them 24 to 4 hours to return that email, and that's different. But then you can have, I think the Tidal Care, because of the data it's collecting, using AI, you can really learn a lot of things. So right now, if you're looking at a video and you look in the ear, you got to guess what it is. If I had somebody helping me through that process, AI, that would be valuable. And after a while, you figure out you do 1,000, and AI doesn't sleep, and can tell me this one really needs treatment, this one doesn't. Dermatology and radiology are done once AI comes out, because, you know, we can use machines. They do this a lot better. And I think we have to just kind of figure out what tele means for you. But in the primary care arena, that's what I mean. I agree with you. These machines in neurology make no sense. I mean, it's a lot easier to just have an extender or a scribe just go and see the patient, because there's no security. God forbid something happens in those intensive care units. See how well that machine works.
I think the bottom line is what this all encompasses for the platform, and what is the platform being used for. So is it a patient-facing app? Is it a provider-facing app? Is it a payer-facing app? Is it consumer? What is it? I mean, our app for multiple sclerosis touches all of this. So it's a mobile app that a patient does a test at home that used to be done in the doctor's office. We score it with artificial intelligence. It's telemedicine, so they can do a telemedicine visit in addition to an office visit. We hope that the neurologist will do 2 office visits and 2 telemedicine visits. We have to have security. We have to have, we're looking at possibly blockchain. So for our application platform, call it what you want, solution that's hopefully helping patients, helping providers, you need all those things. A car needs a steering wheel and an engine and an air conditioning and 4 tires. So I think we want to talk about the overall holistic solution that needs all of these pieces of the pie to be able to do it.
I'm just going to point out, though, in support of my colleagues who are teleneurologists and telestroke neurologists, you know, we have a very robust telestroke program, and when the patient comes at 2 o'clock in the morning, you know, time is brain. The telestroke neurologists all over the country have proven to shorten the door to needle time, and it's, you know, the stroke neurologists in-house in the hospitals. There are not many hospitals other than tertiary centers that can have around-the-clock inpatient neurologists available, and teleneurology has done a great service for those patients. Having said that, where this, you know, when you are, when you are looking at imaging, then okay, you are delivering care through telemedicine, but AI can be driving the prediction, then, you know, recognizing the patterns in the imaging in the MRI, and can help drive the care through the neurologist. So.
At the end of the day, technology has to be good, and our outcomes in this state are not very good. So all this tele stuff that we're using right now isn't working.
So my comment about the slide is that it looks a little bit like a hype cycle. I mean, the stuff that people are using now is what people are investing in, but blockchain is sitting there at the bottom there. It's because it's unproven, untested at this point. I also think that there's a synergy between a lot of those technologies that isn't obvious from the slide. I mean, you're going to have, like you just mentioned, with telemedicine, you can use all of those technologies to improve telemedicine, and yet it's broken out in this very artificial way. So I don't think it's upside down. I just think it's a poor reflection of how these various technologies work together.
Blame Alan, it was his chart.
I think the other thing that maybe it's in another question, so that we haven't talked about, we've alluded to, is just the people involved in adopting the technology, whether that's a clinician or administrator or IT, and just the culture shift in general within healthcare. I had a conversation actually today down at a hospital in Philadelphia. She's MD, PhD, engineer, talking about how in medical school and nursing school, you're not taught innovation, you're not taught technology, you're not, you know, coming into this world. I think we were talking about that earlier. So how can we, one, look at our education system, but really, I think, look at who is in the workforce today. How can we work with them to retrain, reskill, work to the top of the license, but really help them understand what technology can do for them. They don't necessarily have to go off and become coders, but maybe they want to understand the innovation process. And so they're actively working on something, you know, around that area. So I think the people and the process and the culture is also important as we think about disruption.
I also think, and I've been hanging out with CIOs for a long time, and there was a meeting about a year ago that Tony helped to do on blockchain healthcare with the New Jersey chapter of HIMSS. And what was interesting is the CIOs on the panel, and CIOs, again, maybe this broad statement, but are typically risk averse, that they have 500, 600, 1,000 systems in their health systems, and they're typically use them from a lot of big vendors and then some smaller vendors. And when you talk about things like blockchain and cloud and some, maybe not cloud, but stuff that's really cutting edge and bleeding edge, a lot of times those CIOs who in these large health systems, he or she will say, I'll take that from my big vendor when it's ready. So I'll do blockchain when my big vendor is ready for blockchain. I'm not going to take this little dinky company out there and trust them, certainly not with my mission critical stuff. So when my big companies say I'm ready for blockchain, then I'll do blockchain. But until then, it's just sort of this thing maybe someone in the corner is piddling around with. I'd love to get your feedback.
Yeah, Alan, I think you're exactly right. I mean, I come from a small rural hospital system. It's not an academic medical center, so it's not doing its own research. It doesn't have the MD, PhDs doing the bench research on any of those technologies. We're buying technology through our vendors. So most of the innovation that's going to come through will be through the purchase from some product from a vendor.
Shrink wrap.
Yeah, it'll be shrink wrap. Most of it's commercial off the shelf. There's very little that's going to get done in most hospitals around the country. That's innovation that's homegrown. It's going to come through the vendor partnerships, which is why I think when we talk about partnerships, it has to be clear that there's a technology component, there's a clinical component, and those have to come together. I've been in large academic medical centers where there is some of this research being done, you know, but it's not, the average hospital is not actually doing any of this innovative technology on their own.
But there are large health systems in the city, certainly, that are now all starting venture arms and starting to look at some of this stuff. And it's still, I think, still a bit, but they are starting to actually put their money where their mouth is. and invest in things that can work for their health systems and then possibly commercialize and work for many more.
We
They're
do
also-
partnerships with incubators as well.
But still, they're partnership with outside vendors most of the time.
Yeah, but even if you're looking at it from a startup standpoint, we'll fund some of the research that startups will do, but it will not be research that we do in-house. We will help mentor and coach in terms of use cases, but we're not doing our own research.
And like large health systems are used to an approach which requires incremental improvement in processes. Disruption doesn't happen that way.
Yeah, so we're not an elephant. I think what we try to do is really use, our ACO has a health home that does a lot of care coordination. So we speak 18 languages. Hablo mucha diferente lengua. And that's why we like the Azure cloud, because we can attach, we're using its translation capacities, which are really good. And I think we're missing out on that. And also just streamlining the whole process. I think, right now, we're making things more complicated than they are. And I think we have enough technology out there that if you got programmers and you can create your own little entity or your own niche, and then combine with the big players if you need to. Because remember, at the end of the day, costs, everything you add adds costs. We're already dealing with a system. New York State's Medicaid budget, by the way, is $60 billion. So unless you want to pay more into that, I think we have to really, look at the bottom line.
All right, so we got an issue, because I'll go back to what Molly, brought up earlier. Most other industries, when it comes to IT, their budgets average somewhere between 15 to 18% of their total operating budget. And IT in healthcare, it averages 1.75 to 3.5%. You can't be innovative. You can't have an in-house development team. You can't develop all this other stuff when you have a mere fraction of the budget. So for the last 7 years, we've been really hell-bent on meaningful use and putting in EMRs. We want to reduce the cost of care. When we started this process, the gross domestic product healthcare was about 17.8%. We managed to get it clawed back to somewhere around 17.6%. So is EMRs just a lost leader? And now when we bring in artificial intelligence or something else, we're really going to reap the benefits? Or was this something that needed to be invested and, quite frankly, learn from our mistakes and our successes and develop something new?
I think hospitals have really made a big mistake by making major investments in systems. I mean, we have 2 hospital systems in our area where we only need 1, and each one made $137 million investment in an Epic and Cerner, which are worse than what everybody else has had. So, it's sort of just because you build, I think I would have went to Microsoft. They would have provided a much cheaper product, but we're spending billions developing systems that are not going to exist when these big systems take over.
But I will also tell you, down at Northwell last week, they announced that they have a partnership with your major EMR vendor to build their own EMR. So what they're trying to do is, and this across their 18 or 20 or however many health systems they have, they're basically not scrapping it, but they're saying we can do better with this. We can do telemedicine. We can do digital dictation where the doctor walks in the room and starts to talk, and that information is picked up. So they're really trying to change the paradigm of care using the base of the large $150 million system, but they're really trying to have a change. So as you're right, the 4 walls systems that you are good for a hospital, are good for a doctor's office, are good for a nursing home, or good for a whole health agency separately, but never were good together, that has to change tremendously. And so I compliment people like Northwell that are trying to do that and trying to have a tremendous change to the paradigm of how care is delivered.
I don't know if anyone saw the article in the Washington Post, I believe it was last week, on clinician burnout regarding documentation. I know it's probably in every newspaper every week, but this specifically looked at nurses and physicians and quoted a rate, I think, of 35 to 45% burnout, and attributing it to EMR documentation. And I think, EMR documentation, without getting too political, obviously needed to, from my standpoint, needed to happen in terms of digitizing the information in order to collect it. And I know that we work with all of the EMR vendors in terms of optimizing, et cetera, making sure they're moving to the cloud and looking to really insert artificial intelligence so that as clinicians can, are working at the bedside, they can truly, the data is being mined through the technology. They're not spending their time sifting through the data. I've sat with many clinicians to look at the EMRs, and I know that it's cumbersome. And I think it's really, when we think about the entire system, I think it's just going to be one of the apps that we're using in the entire ecosystem. I don't think it's going to necessarily be the end all be all. But we have, health systems have invested millions and billions of dollars. So when I've had conversations about telemedicine or any other point solutions, that they'll flat out say, if you don't integrate with the EMR, we're not doing it.
I agree, but at the same time, I don't know if any physician who would go back and writing on paper anymore. So I mean,
right.
So but EMR, I mean, has led the way.
No, I agree.
Showing how you can use data for improving patient care.
Yeah, no, I agree. But the EMRs that we work with, we actually create. So it's a different vendor, but we adapt and we change it. We run algorithms on it. We run formulas. We move files so that that information can be gathered and read by teams so that the doctor's using the EMR and learning from it. We clone doctors so they follow the same protocols. The way you manage diabetes. Now, the one thing is, how many physicians in the room? Can you raise your hand? Don't all raise your hand at one time, okay? So they're telling us everything, but we're the ones that have to touch the patient, and we also have to work out a workflow so that we all standardize, because we got MIPS, we got every quality metrics, we're in value-based agreements, and you talk about burnout, if you don't simplify the process, and what we've done is simplify. Again, come to Buffalo, we'll show you.
Did you?
Come on, Paul, you got to say something.
The only thing that I was going to dovetail onto that is, I think in general, industry, and this has been my soapbox, is industry really needs to have clinicians involved in the design, the development, and the dissemination of technology, or it's just not going to work. So they need to be involved in every step of the way. And so I've been beating a drum at Microsoft to make that happen, but really throughout my career. So I encourage, you to push back on vendors like Microsoft and others to make sure that that voice is heard, not only in the clinicians, but the patient. Sorry, go ahead.
So I mean, my point would be about the fact that the EMR was a foundational piece of technology that needed to be there. Without it, we would not be able to do any of the advances we're talking about in any kind of digital transformation. But the challenge has been that at the same time physicians have been trained to use EMRs, the regulatory and quality metrics environment has gotten arduous for every physician that I've worked with. And so the burnout and the fatigue is not necessarily an indication that the EMR technology was bad, but an indication of how regulated healthcare has gotten, and the fact that they have to do all kinds of hoops and hurdles to get their bills paid, their quality metrics put through, their CMS mandatory metrics put in. And it's gotten to the point now where you mentioned MIPS and MACRA, another set of hoops and hurdles for people to jump through. I spend my days with physicians and they have no idea how to translate MIPS measures into what they're doing with their clinical practice. They're two separate worlds. So what we need to do is simplify the way in which a doctor practices medicine and also gets paid for their care. Unfortunately, the EMRs we have today are glorified billing systems, and they were designed that way from the beginning, and they have not progressed much since the days when it was purely a billing system. And I think we need the next generation of EMRs. There's work that's being done by all the major EMR vendors right now, but it's been a slow progression. We've had the Epic EMR since 2002, right? So we were an early adopter of the technology. We've spent an enormous amount of time working with Epic proper to try to get them to enhance workflows, to simplify the process, and it's been like pulling teeth, because it's so ingrained in so many of their clients that changing the product at this point is a major undertaking. They're redesigning it, but it's going to be another 5 years before we actually get the product of that labor.
But I would also say you really need the patient voice, right? I go to the big conference every year, the HIMSS National, with 50,000 people, and there's no patients there. So it's all people talking about what patients do, and there's literally no patients there. So they talk about every year we should have, patient panels and all this kind of stuff, because we really need to do that. I mean, you know, what we're building with multiple sclerosis, we need to have engage people that do patient journey and really understand how is the patient really going to interact with the app and how it's going to be ubiquitous, and they use it all the time, just like we do online banking and our kids do Instagram or Snapchat or TikTok, whatever the heck they're doing today. Is it TikTok? I think it is, yeah. So I'm a millennial. I'm a millennial. Come on. So, but the point of it is that how do we engage them seamlessly like we're using these tools? No one's taught us how to use Facebook and all these things, and yet we're looking at them all the time. How do we get our patients to be engaged in these provider tools, to be engaged in their own care if they're diabetic, to all these things? So how do we continue to have the patient tools be as good as they possibly can be, just like we want the provider tools to be the best that they can be, so that it's good for everybody?
Involve them in the process. I mean,
what we try to do is when you go in, you have to give information, right? They want to do a screening. You're seeing the doctor. We have pads that are doing almost like a kiosk. We have kiosks. Now the kiosks are running algorithms in the background, and what they're doing is looking at your blood flow. So if you have atrial F.A.A.F.P, we can actually pick it up while you're doing screening tests. So I'm using the technology in that fashion, and we have great EMRs here in Buffalo. I mean, not in Buffalo. Albany, New York has a company called Community Computers. It's called MedDent. It's the best EMR you can probably utilize because it takes the information physicians are giving it. And it has over 2,800 physicians. And that's worked out a lot better than Epic and a lot better than Cerner.
Tony, where are you? How much more time do we have? 15 minutes? 10. All right. We can either go down the road of, let's talk about the cloud, or let's talk about AI. Show of hands. Who'd like to hear the cloud? Raise your hand.
all right, so there's some questions out there.
You want to have questions? Okay.
Okay, Daniel Guthrie, a physician at Bellevue Hospital, where I work as a staff nurse, wrote in the September 7th edition of The Lancet, keeping the doctor-patient connection from eroding in the age of electronic medical record is an uphill battle. We will be reduced to tools of mere data entry. Are we taking care of patients, or are we taking care of EMRs? Please comment, any of you, on the disruption in healthcare caused by bloated software that is not user-friendly for clinicians to try to care for patients. Those are your questions.
I totally agree with you. The trust between a patient and a physician is built on interaction. And if that interaction is taken away by technology, whether it's EMR or anything else, the trust would be eroded, and that would result in suboptimal patient care. So, and you're right. I mean, I think there's a lot of pressure. I mean, if you go to any physician's ambulatory setting or patient office, there's very little face-to-face evaluation that happens. Most of the times they're talking, but at the same time they're working on the EMR and typing, and the quality of interaction goes downhill. And on top of that, they are told that now you have EMRs which should be reducing the time that you should be seeing the patient. So instead of seeing 20 patients, you should be seeing 40 in the same period of time. So yes, it is a catastrophe, waiting for it to happen, and we need to be cognizant of that, and we need to, reduce or get, as my colleagues on this panel are saying, we should get and invest in better EMRs. That we are data-rich, information poor. We should give the right amount of information for both patients and providers.
I think, when I hear you say that, I think about high tech to high touch, and really how can we put the human touch back into healthcare. There are many times when I've been in an office and been frankly annoyed. I'm like, just look at me, look at the person in the room. One announcement that I just wanted to make everyone aware of: last week, Microsoft announced a partnership with Nuance, looking at ambient clinical intelligence, so that when you're in the room with a physician, a nurse practitioner, a nurse, a PA, whoever that clinician might be, that you can actually have that conversation one-on-one. And there's an intelligent scribe in the background making that documentation happen. So, from a technology perspective, company, we're incredibly sensitive and aware to the fatigue, the burnout, the issues, that fourth component of the quadruple aim, thinking about the clinician well-being and experience. And so, you know, if I think back to that slide that was up there before, thinking about all those different components, how can we bring those into the EMR so that the clinician is having that face-to-face conversation while there's documentation happening in the background?
And again, quickly add, like when we talk about EMR, I just wanted to actually be transparent about it. As a telemedicine physician, sometimes I'm working with 4 to 5 different EMRs at the same time, and we are trying to find solutions. We're trying to find solutions. My team members are here. They're trying to find solutions that they can have a common login. Right now, I don't even have a common login. I have to find. Okay, I forget the password. Call the help desk. Call, So. But, exactly.
So what I've sorry.
We've put the patient and the doctor at odds with each other because we've put the EMR right in the middle of the interaction with them. And I think the comment about nuance, I think that's going to be part of the solution for the next generation of EMRs. It's going to be a dialogue between you and your doctor. All of that's going to be transcribed. All of that's going to be put into the EMR automatically. And all the orders and all the meds and everything that's been talked about will be in the chart, documented and ready to go. So the interaction between the doctor and the patient is meaningful. And at the end of it, the discharge summary of all the things that they just talked about is right there. The doctor's not spending 15 minutes of a 20 visit on the computer typing. Oftentimes with their back to the patient. The logistics, we just went over this, the logistics of many waiting rooms and many operating rooms and many examination rooms is such that there's no way for the doctor to actually use the computer while facing the patient. So, like a chart on paper you could open up and you could still have a dialogue with a patient. There's no way with the EMRs now.
So I have seen the example where for your annual physical, someone comes in and they weigh you and they take your vitals. And then what's the funny part is then they physically handwrite it down and scribble it on a notepad. They leave the room to somehow enter that data in. The clinician then comes in, but they'd ask you ahead of time, is it okay for it to be recorded? So then it is recorded in the room. And so the doctor is able to look at you for that and doing very little data entry typically. And then at the end, the doctor, he or she will then turn around. And if you need a prescription for something or they need to note something, they might do something. But it's a lot better than what it typically would be doing where they're typing the entire time. So you're seeing this movement from the manual paper to this world and this continuum. And we're right in the middle of it. So we're seeing these different versions of this. So they are trying to be cognizant of looking at you in the face and having this be transcribed and to be able to do it, but still be able to do the things they need prescribed and the things they physically need to do as part of the visit. So it's really interesting to see this progression from manual to electronic.
You have another?
So I've been a physician for 30 years and I've been using electronic records for 18 years. I always looked at the patient and I always developed templates. So I would always look down, they would ask a question, look up, and they're looking like, wow, he's really paying attention. You would template so if it was a sinus infection, you know exactly what you needed to template. Doctors are writing the same thing over and over. If he doesn't write the same thing, I could review his notes. And 90% of his notes are the same thing for the same protocol. So what we did with the plan packages or part of the electronic record, it's a menu system. So if you had a sinus, you know what, I'm going to give you this, that, you're going to get this information. I've got to send you to that specialist. We're going to see you. And it's almost like McDonald's. You're actually plugging in that information so you have eye contact with the patient. And then at the same time, you put the EMR can be used for a lot of good things. So one of the things we do is I'll say, where are you going? I'm going to go to Puerto Rico. I'm going to go. My birthday's coming up. I'll put a little signature when you come in next time. So how was Puerto Rico? Oh my God, the doctor, that's a great doctor. So you got to learn to use the tools in a way that the patient feels comfortable. And you touch the patient. There's a lot of things, but if you don't touch the patient and you're back to the wall, then that's not going to work. We're not training doctors for what they need to do now.
You have another question over here, if I could, sir?
Ivan Durbach, CIO, Bronx Care. So this year marks, as Dr. Vazquez pointed out, the onset of massive patient electronic engagement. FAA is just the beginning of that. So with millions, maybe 100 million patients using the technology themselves, how will this change medical care as we know it? Will the big IT organizations like Microsoft and Google and Apple swoop down and buy up all these EMRs? How will it change over the next few years?
Well, Microsoft has Fire servers. So what you can do is you can just tie into their system. We have 3 apps that we created, and all we have to do is map out and actually have like a Microsoft app personalized for ourselves using FHIR resources so that the patient is actually engaged in getting that information at the point of contact. We don't even have to be part of that. So, and we use their resources, which is a lot easier than buying all these servers.
So my comment would be about the data. I think the data is probably the most valuable asset that's being created right now, and patients are now starting to create their own sets of data. So we have this continuum of information about patients, not only when they're sick, but also when they're healthy and when they're progressing towards illness. That to me is the gold mine. And I think you're going to see the big companies like the Microsoft and Amazon and Google trying very hard to capture that information because it will be the diagnostic indicators of health and illness going forward.
Yeah, and just since I do represent Microsoft, our interests really around cloud and artificial intelligence and sifting through the data and really enabling these organizations to do that. So, for example, you mentioned you've been working with electronic medical records for 18 years. We have some systems that have this, they have a ton of data, and what are they doing with the data? How are they looking at it? How are they analyzing it to really improve their care? That's where, big tech, at least from our standpoint, comes in. We don't want to own IP. We don't want to own anyone's data. So that's from our perspective. I can't speak to what other companies are doing, but that's really our point of view.
Yeah, I think if I were to add anything, I think we are getting data from multiple sources. You have wearable devices, your smartphone, sensors, that is sending a lot of data to the health systems, to the providers. And I think what you're going to see, and it's really an exciting time to how we can utilize this data. And the trend, the biggest trend is trying to prevent patients from getting ill or coming to the hospital. So the big thrust that you are going to see is how we can keep the patients safely, treat them in their homes in outpatient settings, and hopefully not only it will increase the quality of care that we are providing, but also lower the cost of care.
And again, I can't predict what EMR is going to buy each other, but when you see someone like a CVS buying Aetna, I mean, those are strange bedfellows that 5 years ago you wouldn't think those two companies have anything to do with each other. But again, it gets to the data and that to be able to bend the cost curve. So I think the continuation of this, you're going to see some more strange bedfellows happening. There's a huge conference right now going out in Las Vegas called HLTH. About 5,000 of the key people in healthcare and healthcare tech and venture capital. So you might see this week some interesting announcements that'll come out. The big healthcare tech, these big announcements seem to come out around these conferences. The big healthcare technology conference I mentioned before, HIMSS, is March of next year. So maybe those 2 times you'll see some more of these CVS and Aetna kind of things that have been brewing, been happening. A lot of the tech companies, there's been a bunch of companies going public in this year. Company like Livongo and Health Catalyst, other companies that one was in analytics, one's in population health or on diabetes and other areas. So there's some really interesting things happening out in the market that are really trying to impact care for the betterment. So it's a wild ride and really interesting to see. This is not a boring industry anymore.
We got one last question and then we'll go for a break.
Yes, the moderator had put up a graph about telemedicine and not cybersecurity. Right, there we go. And what I thought he was trying to get to was, why aren't you putting more money in information security? But nobody seemed to have answered that. And we have a lot, lots of data on the cloud and in your server somewhere. What are we going to do with that in the midst of all this digital disruption? Think of Washington, what's happening.
Microsoft.
Good answer.
So I do think the security and privacy issues are going to come to the fore and pretty quickly. We're starting to see that the Facebook generation who gave away all their privacy is now coming to terms with all that, and the Cambridge Analytica type of events and the things that have happened over the last couple of years are starting to get people to realize that as part of the the use of data. There has to be built-in protections, and security is going to be one of those areas that's going to be a big focus in healthcare. Right now, I think that there's not enough information out there for consumers to understand how their data is being used. And it's a little bit scary when you think about things like even genomics data. Patients are freely giving up their genomic data, not knowing how that's going to influence them in years to come. We don't know how to interpret all of our genome right now, yet, maybe we understand 5–10% of it. But in the future, it might actually divulge information that you don't want public. And yet people are freely giving this information up. So I think there's going to have to be a lot more focus on how we protect consumer and specifically healthcare privacy going forward, especially with these large networks of data that are going to be put out there on the cloud. There needs to be more understanding of how your data is being used. And GDPR just came out last year. California just passed their own Privacy Act. All of these are starting to now come to the fore as we didn't have a good way of protecting the information, and now after the data is out there, starting to figure out how you reclaim privacy, and that's a big concern.
Super. What do we think, folks?
Great.
Okay. Now, before I let them leave, just a couple of little pieces of housekeeping. Can you roll to the last slide? This is one of the reasons why we're able to do this tonight, because all of those sponsors help to cover what's going to happen in the next couple of minutes. As soon as you walk through that door, there'll be beer, wine, and food. That's my specialty, by the way, in case anybody's interested, beer, wine, and food. So we're going to go ahead and do that. But I'd like you to just take a look. Every single one of those organizations stepped up to the table to help us out here tonight. And the biggest winner of all of this is Courage for Carly. It's a children's cancer foundation. Everybody that paid their $10, that money is going out there. And Armand, stand up a second. Armand is out there in the Rochester area. He's going to deliver the check, and he's going to take a picture, which we're going to share with everybody on all 3 websites. Now, Armand, you have an event coming up in the Rochester area, Rochester-Buffalo area, coming up on the 13th?
13th of November, yeah. Innovations in Healthcare, sponsored by the
Innovations in Healthcare, sponsored by?
Ambient Alliance.
Pandemonium? Okay, we got, I got you. So take a look at our website. You'll see some of the events that we have coming up. We're also in the planning stages right now. The event committee doesn't know it yet, but we're going to be doing something very similar to this up in the Albany area. So those of us that are up in the Albany and want to come up to Albany and visit with our governor, and we can complain about healthcare to him, we can get him on board. So one last thank you to the panel. What a great job tonight. Thank you to our moderator. Now somebody open those doors to the food and booze. Okay, let's go. Everybody had a great time. We're going to take this out on the road.